It's absolutely so good to see everybody. We haven't done this in a long time and fantastic. Unfortunately, I have to take off my glasses when I read because I can't read with my glasses on. But if I take them off, then you're all going to look blurry to me. Right. All right. Good morning to all of you and welcome to the academic presentation of the 2022 and Neil McArthur Research Award. My name is Lahana Tabani, and I'm the Vice President for Research at St. Joe's. I'm also the Scientific Director of the Research Institute. So today we'll hear from Dr. James Douketis about a very special journey, one of clots cleaners, and surgery. And this is a 30-year unfinished odyssey, as you can imagine. But before we get started, let's take a moment to reflect on the lens on which we are privileged to serve our community. We at St. Joe's Hamilton recognize the lens on which we provide care, learn, and conduct research are the traditional territories of the Mississauga and the Haudenosaunee peoples. For thousands of years, the first people sought to steward the precious resources of this land and share with others. These territories were the subject with the dish with one spoon, one pen belt covenant, an agreement between nations to peacefully share and care for the lands around the Great Lakes. Here at St. Joe's, we pledge to continue to work together with Indigenous peoples in building a more just society where their gifts and those of other people are nurtured and honored. Ladies and gentlemen, let me welcome Sarah Feliz Menio, President of the St. Joe's Healthcare Foundation, who will introduce the award and the McArthur family. Sarah.
Well, thank you, Dr. Tabani. St. Joseph's Healthcare Foundation is honored to work with our generous community of donors and sponsors and supporters to fund patient care programs, renovations to our facilities, vital healthcare research, and education. Established by the McArthur family, the prestigious Anne and Neil McArthur Research Award recognizes an internationally renowned Canadian researcher whose area of study is also a focus of research at St. Joe's. On behalf of the Foundation and the Research Institute, I'd like to thank the McArthur family for their continued support of research at St. Joe's over the years. Anne and Neil McArthur knew the transformational power of research to advance healthcare innovation, which ultimately changes lives. The hallway just outside this amphitheater is adorned with portraits of all of our deserving McArthur Award recipients over the years. As an academic health sciences center, we're grateful to have so many world-renowned researchers leading in their fields, and this award is a testament to their excellence. This year's recipient, Dr. James Douketis, is continuing the tradition of exceptional researchers to be recognized with this award, and we are delighted that he is being honored today. And now to say a few words and introduce the deserving 2022 recipient of the Anne and Neil McArthur Research Award, please welcome from the McArthur family, Ms. Emma McArthur.
Thank you very much, Sarah. So good morning, everyone. My name is Emma McArthur, and I am here today on behalf of the rest of the McArthur family to honor our very worthy recipient for the Anne and Neil McArthur Research Award, Dr. James Douketis. My grandparents established an endowment fund to support this award at St. Joe's because they recognized how important research and healthcare innovation is, and it has the ability to positively change lives. The Anne and Neil McArthur Award celebrates the achievements of researchers all over the world, as well as those whose field of research is the focus at St. Joe's. Dr. Douketis, this year's recipient, is a staff physician in general internal medicine of thromboembolism at St. Joseph's Healthcare Hamilton. He is a professor of medicine at McMaster University, and also holds the David Brawley and Nancy Gordon Chair in thromboembolic disease. Dr. Douketis received his medical doctorate at the University of Toronto. However, he completed his fellowship in thromboembolic disease right here in Hamilton at McMaster University. For nearly 30 years, Dr. Douketis has been one of the leading experts in thromboembolism in Canada. His research interests include the treatment and prognosis for patients with venous thromboembolism and the management of anticoagulant and antiplatelet medications for patients. He has co-authored over 350 peer-reviewed publications, leading to significant contributions to the understanding of thrombosis. Dr. Douketis is the past president of Thrombosis Canada, a nonprofit organization dedicated to improving the quality of life of those with thrombosis through the prevention and treatment. On top of all of this, he still finds time to be the editor-in-chief of the Canadian Journal of Internal Medicine and is on the editorial board of several other publications. Myself and the rest of the McArthur family are proud to honor Dr. Douketis with the Anna Neil McArthur Research Award.
Thank you very much, first of all, Hannah and Sarah, and thank you very much, Emma, for those kind words. You make it seem like I'm everything everywhere all at once, but it's really just a bit of stick handling. It's not that impressive. And I'd like to thank you all for attending. It's really a pleasure to see everyone in person. As Hannah mentioned, I'll outline my career, unfinished career, and I likened it to an unfinished odyssey. First of all, here are my disclosures, and you'll note that some of the monies that I received, most of them from private sources, I try to funnel back into research or through the foundation. So the overview today, I will try to keep it very simple, and I want to describe to you how studying a common disease or condition like thrombosis is very different than a specific area where you're kind of really drilling down. And here the approach is sort of broader and more on the surface. And I want to outline to you how, what are my personal pillars of clinical research and how they've helped me to navigate through some of these waters, if you will. And then finally, to outline to you just some of the future research that I continue to work on. Now, this award is for an individual, but really the award needs to be shared by many people, the environment, and the other aspects that make it possible for me to carry out this research. So really what I want you to take away from today is not the individual, the accomplishments of an individual, but rather the environment that allows that individual to do their work. And you'll hear more about that. So thrombosis is a very common condition. So there are millions of people in North America that have it. And not surprisingly, there are a number of figures that are well known, actors, athletes, and politicians, world leaders that have had thrombosis or have had anticoagulant treatments. So the approach to something like this is really to keep things very broad, because you're dealing with something that affects so many people. And it's not so much about an individual condition per se, but very broad. So when we think about the journey, and this is my kind of analogy of using the Odyssey, which Odysseus was coming back from the Trojan War and started in Troy here. And of course, took him 20 years to get back home to Ithaca. And along the way, he had a number of trials and tribulations. And different things that reflect what happens in a research career, where there's a lot of unexpected twists and turns. So I'll try to integrate a little bit of that into that journey. So over the years, when I started in 1993 and 1994 here at St. Joe's, these are the treatments that we had for blood clotting conditions. Of course, the third one there, we use in much smaller doses, but patients often reminded me how I'm treating them with rat poison. And in 2023, it's a very, very different landscape. So we have far more choices in terms of blood thinning treatments, anticoagulants that we can use to prevent and treat thrombotic disease. So with that background, my 4 pillars of clinical research, and they're all very interdependent, like the legs of a table, are as follows. The first one is humility, having this as a basis for starting a career, whether in clinical practice or in research. The second part is developing, cultivating a sense of curiosity, asking questions. The third is doing this with a measure of integrity that encompasses a number of other things. And the fourth one, well, I'll let you think about that, and maybe you can consider what is that fourth pillar. So the first pillar for me is humility, and for many people, humility begins as part of one's upbringing. These are my 2 parents. They were immigrants, and my father was a physician, and like many immigrants, they struggled at first to gain a foothold in their new country, and he struggled too as well, gaining a position as a physician. My mother was the anchor of our family and provided us a foundation for all aspects of it. And eventually my father got a position at a small community hospital in Toronto called Central Hospital. And this was a hospital that was for immigrant healthcare professionals, doctors and nurses, and they were invited there. And I put this up because when I came to St. Joe's, it reminded me a lot about Central Hospital. I grew up there, in a manner of speaking. It was a very family atmosphere. And part of my attraction to the hospital here is that there were a lot of similarities with that. But like most immigrants, people have a sense of humility that they start with, that they're trying to achieve something, and at times there are struggles and challenges. So that was a bit of my sort of background. And also there's humility in not just many areas of clinical practice, but also in the areas of thrombosis. So often what we do is we try to treat people with blood thinners, but this can cause bleeding. And then if we don't treat them at the appropriate time or duration, they can cause problems like pulmonary emboli or stroke. So there's this sort of dual sense of humility for me, based on my background and in terms of the work I do, that had an impact on my research. The second part is curiosity. And of course, as a researcher, you have to always ask questions, challenge the current dogma, and try to advance the field, in a manner of speaking. And an important influence for me in my life was my late brother, Constantine, who was a scientist and really imbued with me that related to scientific research, because that is the underpinning of any kind of scientific endeavor. And you'll hear a little bit more about Constantine a little bit later on. So in terms of the research that I was involved with, I'll provide a bit of an overview that is kind of broad, but not too deep. So, I won't be getting into any specific area too much. But the first area that I became interested in was looking at the relationship between hormonal therapy and thrombosis. And this was in the mid-90s. And for some of you that were around back then and were cognizant of world events, a big thing that was happening was what was called the pill scare. So there were changes in hormonal formulations of oral contraceptives, and leading to different areas of research because of an increased risk of thrombosis. So this garnered national, international news at that time. So when I came on, my supervisor said, well, why don't you study this in hormone replacement therapy? Now, at that time, hormone replacement therapy was kind of ubiquitous because a number of studies had suggested pretty well all women should be taking it because it reduces cardiovascular disease, it reduces osteoporosis and fractures, and it may even prevent dementia. So this was something that was ubiquitous, but it was based on potentially flawed evidence that was observational. And in fact, when we studied this and found that the hormonal therapy regimen that was used differed depending on the type of hormone replacement, whether with or without a progestin. So this corroborated a lot of the evidence that was being accumulated for the oral contraceptive. And we thought that was very exciting because I think we thought it would help inform the choices women made in terms of using this medication. But then came along a number of large randomized trials. And the first one was the Women's Health Initiative, which essentially debunked a lot of the research that had gone before and found that, in fact, women should not be on hormone replacement therapy routinely because it does not reduce heart attacks and strokes. It does not reduce certain mortality from other diseases like cancers, and in fact may be harmful. So now that provided a sort of sea change in the approach. But from my perspective, it wasn't as captivating to study that going forward. So in a way, it was a bit of a port of call along my journey that I had to just sort of let go of and pursue other areas. So this is an example, though, of asking a question, asking it the right way, designing a study to answer that question and having a clear answer. And this is the underpinning of clinical research, keeping it simple. So then, because I was here at McMaster, which was really an epicenter of thrombosis, research for venous thrombosis, I became involved in some research areas in thrombosis, but not so much in diagnosis because there were a lot of very capable, smarter people looking at diagnosis, prevention, and treatment. And being a little bit of a contrarian or wanting to look at something off the beaten path, I thought, well, why don't we look at prognosis? And what does that mean? It's not as sort of catchy or doesn't get as many headlines or isn't as provocative for medical journals, but patients come to you and say, doc, I have this blood clot. Number one, I hear that it could be fatal. So am I going to die from this? And secondly, will this happen to me again? And to me, these were important patient-related questions. Of course, the other aspects, diagnosis, prevention, and treatment are important as well, but this was a clinically important question for me. And it was something that had not been addressed adequately. And to me, it was also duly important because it provided information on how to treat patients, how long to treat them specifically. So I focused this area because there was an unmet need. It was a question that had come up when I was assessing patients, and I thought it was important for patients to have that information from their care providers. So this led to a number of different studies with individuals, and what I want to highlight here, and I'll do that again, is how, in my case, a lot of my work was in collaboration with many other people. So as I said at the beginning, this recognition is really a kind of more global recognition of my colleagues and the environment where I was allowed to pursue this research. And to distill this into something very simple, what we found is that, if you get treated with a blood clot or get treated with a pulmonary embolism, then your risk of dying is actually very low. So I think this was reassuring to clinicians, but also emphasized the importance of the first two parts of that algorithm, if you will, which is early diagnosis and early treatment, because delaying that may lead to adverse outcomes. And I'm going to come back to this a little bit later when we talk about taking all these concepts and ensuring that the general public is aware of them, and through my involvement in thrombosis. Thrombosis Canada. But the other part that this research led to is a little bit more complicated, and found that when you're looking at the risk of somebody having a second blood clot, what is that risk if they stop the treatment versus what is the risk of bleeding if they continue the treatment? So it's a little bit of a more complicated formulation, but as clinicians, you distill it into something very simple in that you want patients to be informed, and nowadays the dialogue is very bidirectional, and we incorporate patient values and preferences. So some people, they want to have that security of being on anticoagulants, but what is the risk for that? Others don't want to be on a blood thinner, but what is that risk? So this is the area that we tried to provide a bit more clarity on. And this was done in my effort more as a facilitator. So in this case, I wasn't doing original research, but I was facilitating answering the question. And how did we do that? Well, I somehow got 7 different investigative groups together to convince them to collaborate. And of course, in the medical field, you're dealing with different personalities and sometimes, egos. So it was a bit of a challenge, but we managed to put together a very large database in those days. So this is in the 2000s of over 2,500 patients with the type of blood clot, which we called idiopathic or unprovoked, where this question was most important about, what to do next after that person was treated. And as you see down below here, this is a large group of patients that received a diagnosis, were treated for about 6 months, and then went off treatment for about 2 years and had a period of observation. They had a number of tests after they stopped anticoagulation. So our aim was to sort of look at the patient next to us and say, okay, you have approximately this risk of having another blood clot. You have approximately this risk of having bleeding and complications related to bleeding. So it was meant to be very practical and very patient-centered. And this, of course, led to a number of other publications and collaborations with colleagues in many parts of the world that I really could not list here. And then ultimately, it led to the development of what we call a clinical prediction guide or score. And what is that? Well, first of all, what we looked at is what are the things among people who have blood clots that predict them from having further blood clots. So in people that, let's say, have a heart attack, you think, oh, that person is a smoker. Okay. You stop smoking, you lower your risk of having another clot, or you exercise more and you lower your risk of having another heart attack. That premise it was not as valid in the case of venous thromboembolic disease, because it's a different sort of pathophysiologic paradigm. And what you'll see here is a number of factors. So age, body mass index, sex, hormone therapy, duration of treatment. And what you'll see is that there are very few things that actually predict whether that person's going to have another clot. And I know when Lahana and other, statistically and methodologically oriented people look at this and they look at those odds ratios, those risk ratios, they're not very robust. They're not very strong. So we're looking at a different kind of paradigm in terms of predicting outcomes. And this slide here, which I have to acknowledge the late Clive Kieran that provided this, shows how there's various factors involved. So trying to generalize how this condition will behave in an individual is very difficult, because there are a multitude of factors that are associated with a lower risk. So if you have a clot after surgery, then you're less likely to have another one. Whereas if you have a clot outside of surgery, just out of the blue, then you're more likely. But you'll see that those risk ratios are still not very robust. So what this led to was that when we developed this score, we were only to identify a few factors that could predict. So this was disappointing in some ways, But that's the reality. And this is what you're trying to achieve ultimately in scientific research. Get as close as you can to the truth, but also at the same time, allow others to kind of critique it, reevaluate it. And there are other prediction scores in this area, so that at the end of the day, you can sit across in that room with your patient and say, you know what, this is what we think is your risk of having another clot. If you go off treatment, this is what your risk is if you continue treatment. And then what about you? What do you want? What do you value? And it's a very personal, very individualized decision. So although these are schemes and algorithms that are developed for a large population, and our aim was to inform how an individual physician dealt with their patient. So moving on to the next port of call along this journey, and this relates to anticoagulants and surgery. So what do I mean by that? Well, as I said before, there are millions of people in North America, I think about 4 to 5 to 8 million approximately, who are receiving an anticoagulant, a blood thinner. And many of those are older, and many of those older people will require surgery or a procedure. And of course, blood thinners and surgery don't really mix very well, because if you are taking a blood thinner and you have surgery, then this may lead to excessive bleeding, which of course we wanted to avoid. And my sort of thought was that this is an area that we're not really looking at, but it happens all the time. And it's not just on the ward in somebody having an orthopedic procedure, but I thought, this is something that gastroenterologists deal with when they're doing endoscopy, or dentists deal with when they're cleaning or doing some dental work. And I thought this is something that really warrants studying, because it's common and it'll be increasingly common. And it's a little off the beaten path as well, because it wasn't sort of in the domain of cardiology or hematology. And as a general internist, it sort of appealed to me because it was not very kind of focused on one special area. So I looked at this as an opportunity to advance the field by providing some clarity about how to deal with people, the increasing number of people who are taking a blood thinner and needed a surgery or procedure, and helping navigate them around that. And I want to acknowledge a couple of people here. This is Dr. Graham Turpey, who provided me sort of a start in this area through his involvement at the Hamilton General, and Dr. Mark Crowther, who is the chair of the Department of Medicine here and a longstanding physician here at St. Joe's, who convinced the hospital about 25 years ago to develop a program in perioperative antithrombotic management and to provide funding for them. So here's yet another example where it's not the individual, it's the team and it's the environment that allows this research to occur initially at the Hamilton, at HHS, and then here at St. Joe's. So what was the big controversy when I started all this? The big controversy was this concept of heparin bridging. So what does that mean? Well, what it means is that, as I alluded to, when somebody's on a blood thinner, they need to stop it before their surgery, because you don't want them to bleed excessively. Heparin bridging meant that you stop a blood thinner, and in that case, at that time, it was the rat poison, warfarin. And the warfarin, sort of takes a while to get out of the body and then a long time to get back in. So during this time, when you're stopping the warfarin, patients are exposed, in a sense, to blood clotting, because they're not receiving an anticoagulant over a 2-week period of time, and you don't want them to get a blood clot. So what are you going to do to reduce that risk? Well, you stop the warfarin, and then you interpose another blood thinner, which is heparin, in between the stopping and the resuming of the warfarin. And this was essentially the dogma. And when I started off my career, patients would actually come into the hospital about a few days before surgery, to stop their warfarin, get put on heparin through an intravenous infusion, have their surgery, resume the heparin, and also go back on their other or anticoagulant. Can you imagine that happening today? There's no way that would happen, because people come into the surgery, they have major orthopedic surgery here at St. Joe's on this morning, and they'll go home by supper time. So this was a paradigm that had an effect on how we manage patients, but it was also a paradigm that had not been really validated, but it was entrenched in the dogma. So if you weren't doing it, it was kind of considered bad, and you were exposing patients to an increased risk for clotting. Now, when we sort of looked at this and look at what happened around the time of surgery and preventing clotting, and stroke is an example of clotting, it's a very serious example, a life-altering example of a clotting mechanism. We thought that there were so many factors involved in the development of the pathophysiology of clotting that what effect really is giving this sort of short-acting blood thinner doing? Is it really affecting any of these other pathways, so that at the end of the day, you're reducing the incidence of clotting, in this case, stroke? And on the other hand, you're giving these blood thinners around surgery, and if you don't do it right, are you exposing patients to an increased risk of bleeding, which is a bad thing around surgery, because it may require, reoperation, and then you're stopping the blood thinners for even longer, which is something you want to avoid. So yes, bridging was something that had to be done precisely, with exactitude, but we thought maybe it was kind of more along this line here. And maybe it wasn't as cut out as it was touted at. And this led to another publication with a number of other colleagues here in the US, in Canada, and in the US, which really in itself was an odyssey, because from conception to completion, it was at least a 10-year period, but it was a very rewarding study for me. It was partially rewarding because we asked a very simple question: do you need to have this heparin bridging or not? Yes or no? And simple questions lead to simple study design, lead to clear, actionable results. And to me, this is a paradigm that was imbued upon me, not just back to my upbringing as a child, but also when I came here to McMaster, which cultivated this idea of this mindset of asking simple questions, developing simple studies to answer the questions so you have meaningful results. And this is from the paper. It's a bit busy, but essentially it tells us, it shows how the study was designed and what the protocol was, so that we could evaluate this. And the reason why there's a lot of wording there, this was a double-blind placebo-controlled trial. So patients received during the trial either injections of the real heparin or injections of a placebo, sort of sugar water or salt water heparin that had no effect. And the other part of this that we built in was to say, okay, if the study just fails completely, then what we will have at least is a standardized protocol that we can use. So let's say the study showed that, we need to be bridging people because it reduces stroke and it doesn't cause any excess bleeding. So in other words, that was against our hypothesis, where it doesn't prevent stroke and causes bleeding. Even if we had failed, we would at least have had a protocol in place that could be used to give this heparin bridging outside of the hospital. So people didn't have to come in and use up resources unnecessarily, but they could do it in a way that was safe. So at the end of this 10-year kind of mini odyssey within an odyssey, this is the table, the 3x2 table that encompassed that entire body of work from myself, many other colleagues here at St. Joe's, at HHS, and other sites in the US. And this is one of the few times where in clinical research you have that kind of moment that everything just comes together. Because not only that did our first hypothesis be validated that it does not have any effect on clots, but our second hypothesis was also validated that it actually causes more bleeding. And even under an environment where the design was such that we wanted the bridging approach to succeed. So even when all the eggs were put into that basket, it still validated our hypothesis. So it was very rewarding to get this result and to share it with a number of individuals here. And this led to a number of algorithms, protocols, which are not really important for today, but just to outline to you, it helped to standardize practice in this area. And whereas before it was a bit discombobulated, and now we had an evidentiary basis to recommend how you manage these patients that were increasing in numbers because of indications for anticoagulant use and increasing numbers who were having surgery. So all of this work, 10 years of work and a number of years before then, could be encapsulated in this one simple figure, which once again, I won't really go into, but this is what clinicians want. And this is also what is important in our current practice. So St. Joe's and many other hospitals have an electronic medical record system. And that system, despite sometimes we complain about it, is perfect for these types of algorithms to be incorporated into a standardized practice. And it allows hospitals that may not be as sophisticated as St. Joe's, where we have a dedicated service, but it allows any hospital to benefit from that knowledge by incorporating this into a standardized algorithm, preferably through the EMR, so that really it levels the playing field and offers patients the best chance to get through their surgery and procedures with the minimum of adverse consequences. Now, that study was looking at patients who are on warfarin, but in more recent years, we had these newer blood thinners that were touted as maybe a little bit safer, maybe as effective, but certainly a lot easier to take. And why is that? Is because with warfarin, you needed to have blood tests done every 2 or 3 weeks to monitor the blood thinning levels, because they could go up or could go down, and you would adjust the dose accordingly. With these newer blood thinners, all that was out the window, and all you did was take the pill once or twice a day, and you were kind of good to go, and you did not need any blood tests. So they really advanced the field in a revolutionary manner over the last 10, 15 years, but they also offered some potential safety advantages over that of warfarin. So what does that mean, that all that research has kind of gone to bunk? No, not at all. In fact, it was something that was used as a basis to design studies on how we manage patients who are taking these drugs and once again require a surgery, a procedure. This is another very large collaborative effort through where here at St. Joe's, we were one of the leading sites in recruiting, and I'm going to talk a little bit about that later. But what it did was it provided this sort of simple approach. And I know it's a little bit busy when you look at it, but really it mirrored what we did in those patients who are on warfarin by providing something that could be easily adapted into whether it was EMRs or standardized protocols. But most importantly, and I can't emphasize this enough, is just getting back to the patient and being for that healthcare professional to convey to that patient, okay, this is what you do with your blood thinner. Patients would say, somebody is before the study, well, I'm stopping this blood thinner a week or 2 weeks before because that's what my doctor said. And then they might go to another doctor and say, well, no, you don't need to do that. You can just stop it, 2 or 3 days. So, the patient was often caught in the middle because these were new drugs. We didn't know how they kind of reacted under these sort of circumstances. And frankly, the companies that studied these drugs and developed them they weren't really as interested in what happens around surgery because frankly, there wasn't any commercial advantage to them. But there was an unmet need from a clinician standpoint and a patient standpoint to provide some clarity in this area. And this sort of protocol encompasses that work, if you will. These are the results of the protocol, which we aim to show that was associated with low risks of bleeding and low risks of arterial thromboembolism, mainly stroke. So in a way, it validated our thinking, but really provided a first step, and there's need for further work to not only validate this work, but address other corollary questions. But at the end, the message was that we can now take people who are on any kind of blood thinner, whether it's warfarin or any of these 4 newer drugs, and guide them through procedures and surgeries in a way that we think is safest for them, and at the same time is easy for a patient to incorporate. So our nurses here in our perioperative anticoagulation service do a great job of this, but this can also be applied to places where that service is not available, and it provides simple instructions for patients, which at the same time has been rigorously studied. And this is another sort of paradigm of that approach that different institutions can use. So once again, we're talking about sort of broad things, more on the surface rather than kind of drilling down on specific facets of this management. So now we move to the third part, which encompasses integrity. And integrity can mean different things to different people. For me, integrity in the area of clinical research means that you are collegial, you are collaborative, you welcome and incorporate views of others. It means that you are reliable, that you, when asked to do something, you get it done on time. And it means that you do it with integrity. So, you let the data speak for itself. You're not there to sell anything. That's what the data are for. That's what the studies are for. And in fact, you want people to criticize it. You want people to challenge you. You don't want to sell it as, yes, it's a good study. You want that because that provides the validation, and that provides the overall the integrity of that research. So to me, there are 2 individuals that personify this integrity the most, and there are others as well that there's just too many to mention, but the 2 foremost in my mind are Dr. Jeffrey Ginsburg, who was my initial supervisor and in fact helped me get a position as a clinical scholar here at St. Joe's in 1994, and Dr. Deborah Cook, who I'm sure you all know, who really is a paragon of clinical research, an awardee of the McArthur Foundation recognition, and many, many other honors. And in fact, I've kind of followed her career surreptitiously because I was so intimidated by her. But at the same time, she carried herself in a way, and both she and Jeff did, in a manner that allowed me to have that kind of role model, because research can provide some twists and turns. There can be other influences, if you will, and to just keep things straight and focus on the question, providing a simple design to answer that question and letting the data speak for itself is embodied by the work that these 2, in my view, giants have pursued. Now, the integrity part is also being considered somebody that, we can count on. And this is also very important for me because not only did I want to work in the area of perioperative practice, but I wanted to help disseminate this knowledge. And how do you do that? Well, there's a number of ways. One of these ways is through clinical practice guidelines. And these are kind of ways that clinicians use to disseminate knowledge. And I was really privileged to lead 3 of these guidelines over the past 12 years or so. And these guidelines, I hope, will provide the partner to the actual research, which deals with not just patients who are on warfarin or the new drugs, but other situations as well, patients who are taking antiplatelet drugs or less commonly used anticoagulants. So this is something that, once again, is only feasible because of the environment. The first guideline was developed through the mainly McMaster-based clinicians and scientists, and then it's evolved later on to encompass other guideline groups, and then more recently involving people from all over the world. But just as an interesting side note, this was the first sort of guideline that I had published and was involved with, and this was through a collaboration with the Canadian Task Force of Preventive Healthcare, which has gone through a number of iterations. But this stemmed from a project as a graduate student at the U of T, and I eventually kind of flunked out of that program, especially after my statistics course. But this was my course assignment, and my assignment was to look at the literature on the treatment and prevention of obesity, because back in the 90s, there were all these treatments that were being used, like fen-phen and so on, that were very harmful to people. And my task was to summarize that sort of evidence as a basis for our group to provide recommendations. And some have thought that this was a landmark study because it provided a rigorous approach to prevention, treatment of obesity, whether it was dietary therapy, pharmacologic therapy, or surgical therapy. And we had thought we had done a good balanced job, but this was also my first interaction with the media. And in the Spectator, there was a big newspaper article, and it's not exactly this, I couldn't find it, that diets don't work. And I got a lot of sort of dirty looks the next day from people in the hospital. What are you saying diets don't work? Well, we weren't really saying that. We were just kind of summarizing the evidence. And you and your physicians or nutritionists, you have to decide. But it sort of provided an example long ago of how the message can be a little bit changed. And of course, we've seen so much of that. I'm referring to misinformation or twisting of data over the past 2-3 years. But this was something, a bit of a wake-up call. And I think it alerted me to say that, once again, you let the data speak for yourself. You're not there to sell anything, to shortchange it, or to make it seem better than it is, but let the data speak for itself. The other area that I was involved with in terms of using this knowledge that we've accumulated, and not just within here at McMaster, but you probably don't know that Canada is sort of the major hub of thrombosis research worldwide, relative to its size and relative to the number of individuals. So in sort of sports parlance, we punch way higher than our weight. And of course, McMaster is an important component of that, but really there are researchers across Canada that have contributed to this fund of all knowledge. And I'm just one of those individuals. There are many others. I'm not mentioning them. There are just too many to mention, both locally, regionally, nationally, and collaboratively with international groups. But I was very proud to lead this group for about 10 years and to develop areas that we could provide reliable information. And during the COVID pandemic, there was a concern about COVID and clots, and there was a concern about vaccines and clots, and we aimed, and I know our executive director here, David Airdrie, led a lot of this to help inform the public, not sell anything, do this, do that, but just inform them and provide some reliable guidance from individuals that really were seasoned clinicians, researchers in this area. And very importantly, we also provided information for patients and their families, because as I alluded to at the beginning, blood clots can be a very scary thing. People think, oh, can't you die of a blood clot? Well, yeah, you sort of can, or doesn't this blood thinner, could I not bleed to death? There's a lot of questions from patients and their families. And the work that we've done through our colleagues at Thrombosis Canada has, I think, helped to inform clinicians about best practices, but also help inform patients and their families and provide them a reliable source of information. So I'm coming to the end of the presentation happily for you. And so the fourth pillar of clinical research, and any takers out there what that might be? Lahanna?
Family.
Close. Think more broadly. Yes? Yes. Well, I don't, yes. I've been having fun for the last 30 years. Well, you're kind of all hitting on it. It's community. So community means, again, a lot to me. This was my community a number of years ago and continues to be the community of team and having fun and people that I've worked with that really should share this award, that this is not an individual award. This is really, a team award. And these are some of the individuals that have come, some of whom have come and gone. Terry Schnurr is a nurse that has been here for, I think, almost 20, better part of 25 years. And then we have two other nurse practitioners that are part of our team, Lori Sardo and Julia Bayadanova. So really this reflects a community within the thrombosis service and program, clinical program and research program that was cultivated here at St. Joe's. And of course, yes, Lahanna, family is an important part of that. I have two sons that are here, Jack and Luke, and they are really a source of strength for me and a source of pride for me. And this is something that underpins any kind of endeavor, but certainly helped me to navigate through a lot of the ups and downs of clinical research, knowing that they were there. And then the third part of the community relates to the environment. So here I am just before the pandemic with a couple of friends. We're playing some music just down the hall here in the lobby of St. Joe's. And I alluded to earlier about how I grew up in a small community hospital in Toronto, Central Hospital, and how St. Joe's had many of those characteristics for me, and in that we felt we were part of a family. You got to know the staff in the cafeteria, the cleaning staff, the paging staff, and we really felt like we were a community within a community. And I love coming to work. I mean, some clinicians go to work and it's a stressful, difficult environment. Every day I've loved coming to work at St. Joe's. And of course, clinical research can have its ups and downs, but having that sort of security, that kind of warm refuge or, safe harbor where you go to work, you feel safe, you feel, appreciated. And above all, you feel like you're part of the family. I can't emphasize how important it is. And many individuals along the way here at St. Joe's have had an impact on me. This is Sister Patricia Hanlon. And she, would always say hello to me and ask me, "Oh, how's Jack and Luke?" Our younger son was born here, actually, and would always ask me about them. And a tremendous number of colleagues, and we all sort of mourned the loss of Dr. Anil Kapoor, a wonderful, charismatic, Hollywood good looks individual who was also a very skilled surgeon. And so when we are with individuals like this, we really do feel we are part of a family, and that sort of underpins being able to undertake research hopefully in a successful way. And then coming back to my brother, who was actually cared for here at St. Joe's and died sadly of pancreatic cancer at age 55, because of his love of science and wonderment of nature, but also because he encouraged, young people to pursue careers in research. I was very happy through the foundation and the hospital and the Research Institute to establish a award in his name for aspiring young clinician investigators. And these are the two recent individuals, Dr. Kim Lewis and Dr. Lonnie Pine. And it's been very grateful. I've had a tremendous gratitude in being able to learn about their research and use it as a springboard for their research careers. And I hope to be able to continue doing that in future. So we're kind of come to the end of this odyssey. I've got about 2 minutes left. And the finish is in Ithaca after about 20 years of going around the sea there. And this is Penelope. So she's dutifully waiting for Odysseus, her husband. So there's one person I haven't really mentioned in this journey. This is my Penelope, Dr. Margaret Novacek, who not only is a pediatrician, a geneticist, but she's a critically acclaimed writer as well. And I can tell you, Margaret isn't waiting for anybody. So with that, these are some areas of research that myself and others are continuing to work on. Won't go into them in detail, but they relate again mainly to dealing with blood thinners around the time of surgery, including some of the newer agents that are being developed, the 11A inhibitors. And this will hopefully provide me with some additional work and for me to continue my odyssey. But in closing, really, it's not the individual that should be receiving this award. This award is a reflection of an entire group of people, both locally and within the university. And it could not certainly have been possible if I had been at other institutions or other hospitals because of the environment where, it's a joy to come to work. So with that, I do want to thank the Research Institute, the foundation, and above all, the hospital for allowing me to do this work and hopefully continue doing it. And thank you very much for your attendance and joining us in person today. Thank you.
I don't think we have time for questions. That's okay. Fantastic. That was fantastic. Yeah. Wow, what a treat. I hope you guys learned something like I did. Thank you, Jim, for such a fantastic story of your journey. And, we feel privileged, to actually work with colleagues like you. And I know your work has meant a lot, not only to your colleagues here in the hospital, but to the many patients whose lives you have saved and their families as well. And I can't thank you enough for actually doing this. And again, let me thank Emma on behalf of the Research Institute and the hospital for the family's continued support of the McArthur Award. We greatly indebted to the whole family for creating the award and celebrating what many of our researchers do at St. Joe's. And thanks to the foundation for continuing to be really a pillar of support in what we do at St. Joe's and within the Research Institute. And thank all of you, because the environment that Jim is talking about is not created by the buildings, it's not created by all the resources we have, it's created by people. It is the people that create the environment. And we are all beneficiaries of your collegiality, your warmth, your kindness. And we hope that you'll all continue to, live that spirit of collegiality and community, which makes us all thrive, because all of us are. And that's really what keeps us all going. And let me thank you again for coming. And unfortunately, we don't have time for questions, but Jim is available. We have his email address. So send him an email. I'm sure you'll be happy to have coffee with you to answer any questions you have. And thank you again. I know you have lots of work to do and things to get back to. And then we'll have Jim and the family to take a few pictures. And thank you, everybody. Oh, by the way, one last thing. I have to thank two most important people really. It's Laura and Mike. They are the people really organized. I know, none of this really would have been possible without, like, they even had cheat sheets for us what to say and what not to say. All right, thank you guys. Thanks, Laura. Thanks, Mike, and all the team that made this possible.